All right, everybody. I'd like to introduce you Beth Mallow. Again, she's professor of neurology and pediatrics with the Vanderbilt University Medical Center, and she is an expert in sleep. And Beth, we're so happy to have you here. Thank you so much, and the floor is yours.
Thank you so much. Well, those are great questions. I was really blown away I couldn't even keep up with the chat. There was so much in there. You will hear some of what you've recommended today in my presentation. What I want to try to do though is put it all together for you, because I know as a parent myself how overwhelming it was and still is to feel like, oh, I'm going to try the weighted blanket. Oh, I'm going to try the theanine. Oh, I'm going to try the bath. I'm going to try to collect data. I'm going to try to do this. Well, the collecting data I know is important, but the idea is there's so many different things, right? And it can be really overwhelming. And as you'll learn, it's very touch and go, right? It's like when we see one child with autism, we see one child with autism, and they're going to respond to different things. So let's go to the next slide and get into it a bit. Okay, so just really quick, I am a consultant for Neuron Pharmaceuticals. They make an extended release melatonin product. And I also discuss off-label uses of medicines for sleep because frankly, there aren't that many, there really are very few approved medications for sleep. Next slide. I'm going to talk about in the next half hour the causes and contributors to sleep problems and autism, the impact on the child at school and at home, and which treatments work. Next slide. I have my own case. I don't want to be too redundant with cases, but I'll just briefly go over Alex because he's a little bit older and there's some other things that are different about him that we can learn from. So he's 10, he has autism, he also has ADHD. His bedtime is 8 p.m. He takes hours to fall asleep and he can't shut his brain down. That's what his parents say. And he admits that too. It's like, go, go, go. Similar to the case you guys talked about. He takes methylphenidate, Ritalin in the morning and afternoon for ADHD symptoms. He also enjoys a glass of Mountain Dew, which we know is a lot of caffeine, plays video games after dinner, and he can't settle down to go to sleep. He leaves his room to find his parents. They rub his back to fall asleep. They stay in the room with him until he falls asleep. And then they leave, and then he wakes up multiple times a night. He comes to their bedroom, falls asleep there, snores loudly, kicks his legs, and mornings are really hard. He really struggles. He's described as being sleepy and hyperactive, and his parents are exhausted and overwhelmed. I don't want to belabor this too much because you had an excellent case, but why don't we take like 3 responses and you could put them in the chat. Things that stuck out to you about Alex that you think could be addressed, and maybe things that we didn't talk about with the first case that are unique to this case. Yes, thank you. The snoring apnea can use a sleep study. Excellent. Everything here sounds okay. Possible sleep disorder causing poor quality sleep. Ritalin. Yep, Ritalin. Excellent. Let me just take a peek. What time is he getting his afternoon booster? It's a great point. That Ritalin may be too late in the day, maybe okay in the morning, but not in the afternoon. And thank you for that. Thank you for all those comments. And I am happy to talk with you more in the Q&A about autistic sleep disorder and your impressions of it. I appreciate that. And then the video screens, I agree, that is an issue as well. So great, you guys did a great job. Thank you for thinking of all those things. The point I wanted to make with this case is it's multiple things. Oftentimes it's not just one thing. It's what we call multi-dimensional or multifactorial. Let's go on to the next slide. And what I've done on the next slide is I wanted to just throw in the caveat that resolving the snoring with removing the adenoids and tonsils a sleep study was done, it documented apnea, the adenoids and tonsils came out, snoring got better, ADHD got a little better, but he's still taking an hour to fall asleep. He still wakes up at least once a night and he's very restless. So if we go to the next slide, you'll see all the different things that I like to think about and I like to teach. And I try to do it in a way that's easy for people to follow. It's easy for parents, it's easy for clinicians. I use this 3-bucket method. So we've got the medical conditions. I always start there. We don't want to overlook apnea, leg movements. It's very important that we look at the medicines a child is taking, like the methylphenidate in this example, when they're taking it, making sure that stimulating meds are in the morning, and medications that calm children are more toward evening, if you're on a medicine for those reasons. And then the other huge area is biological. So this is your arousal regulation, which we know can be affected in children on the autism spectrum. Processing of melatonin can be affected. Genetics can be affected. And behavioral is the huge category. Behavioral, environmental, making sure there's limited caffeine, limited screens, sunrise, sunshine in the morning, and less light as the day goes on. And these behavioral techniques really do work. So we'll focus on them, but we'll also get into some medicines as well. Next slide. We have developed several practice pathways in our work that include asking the pediatric provider or clinician to screen for sleep problems. Not always the easiest thing to do because they've got so many other things on their plate with vaccines and everything else, but something we really try to do. And then those medical co-occurring conditions, whether it be sleep apnea, reflux, GI reflux, whether it be epilepsy, seizures, various other conditions, so important because those can disrupt sleep. And then I always start with behavioral strategies if the family is willing and able to implement them, and use medicines sparingly. What do I mean by if the family is willing and able to implement them? What I mean is some families are so overwhelmed and stressed that they can't even think about putting a bedtime routine into place. They're just stressed and overwhelmed. So what we'll do is we'll work with some medicines temporarily to just try to jumpstart the bedtime routine. Sometimes melatonin will work. Sometimes something else is needed, but we'll do that occasionally. We'll also try to use medicines to facilitate behavioral strategies that are already being used. So what I mean there is treating the co-occurring conditions already, like, for example, a medicine for depression, a sedating antidepressant or anxiety medicine could be used at night to promote sleep. And that's a conversation oftentimes with a child's developmental pediatrician or psychiatrist. I wanted to highlight on the right here, we've developed toolkits through our Vanderbilt Kennedy Center. So if a child does need a sleep study to rule out sleep apnea or evaluate for a condition, we can make it easy for the family with various visual supports and other things. So all of this we can make available. I think I provided it in the resource sheet. If I didn't, I'm happy to add it. Next slide. And why do we address sleep? Not just for health. Sleep is important for good health, but this particular population, emotional regulation, behavior, and even core symptoms can be improved when you improve sleep. And these are studies that have shown that, like, if you do imaging studies, the part of the brain, the amygdala, which is involved in fear and anxiety, is activated when we're sleep deprived. And the part of our brain, the prefrontal cortex, that keeps our amygdala in check, our emotions in check, is affected. And we all know this, right? Because we know that when we're sleep deprived and we haven't been sleeping well, we tend to send that snarky email, right? That we'll regret later, or that tweet or whatever. So it really is true that not getting enough sleep affects our emotions. And our kiddos are already affected, right, by emotional reactivity and all. So this is a huge area to help people. And even some of these core symptoms like communication delays and repetitive behaviors have been shown to be effective. When you sleep better, you have fewer problems. And I think when I talk to therapists, it makes sense, because if a child is not sleeping well and a parent is not sleeping well because the child isn't sleeping well, they're not going to progress in therapy to the same degree as somebody who is. So it does play a huge role. And this is a study that Masrick and Sol did, looking at an association between sleep problems and aggression, irritability, inattention, and hyperactivity. Next slide. So I hope I've convinced you that treating sleep is important. And this is my little guy when he was young. He is doing really well now. He's actually out of college and doing really well. We did sleep training with him, and it works. It really does work to do these behavioral strategies. The challenge that I see is, how do we translate it into our practice? How do we deliver it and motivate parents who are really stressed, as I mentioned? And when do we use medications to kind of jumpstart things? So next slide. And what I like to do is very parent-centered. It's not a one-size-fits-all. It's not focusing on putting a weighted blanket on the child at night or giving them some melatonin. It's actually looking at the whole child, the whole family, and what goes on all day long. So what's going on in the day, the evening, the environment at night, and the bedtime routine. And we'll go through these one at a time. I just wanted to point out, this is the family inventory of sleep habits that we developed because we wanted to have a quick and easy way for parents to fill out a form when they came to see us that went through exercise, consistency of bedtime, wake time, caffeine. You can see from this, and this is something that I included in the resources as well. So we can get a sense of what areas we wanted to target, because it's too much to target everything. And if a child is already involved in physical activity or has a dim room at bedtime, why spend the time? Let's focus on the things that really matter to the family. Next slide. So daytime, we don't want to forget the daytime. We're looking at the whole day, whole night. So exercise is super important. Getting light in the morning, limiting caffeine, all the things you guys talked about with your case. Making sure we use the bedroom, not for timeouts, not for homework, but if we can, but really just use it for sleeping. If it's a small house and that's the only room the child has, at least making sure they're doing things at their desk rather than in their bed. Next slide. That way you break the association between something else and sleep. And then as we get into the evening, limiting stimulating activities, less light, routines can be very important. Next slide. As we get into the environment, this is key. And this is like that one size doesn't fit all situation. It's not necessarily a dark room and no noise. My son, who I just showed you, Daniel, he needed it to be somewhat light in the room with a night light. And he also needed noises to be filtering in from the rest of the house so he didn't feel scared. And so he didn't want the shut door wasn't going to work for him. So every kid is different, and you just have to figure out what works for your child. Next slide. And then the bedtime routine is really magical in this population, either the line drawings or the checklist. There's something really magical in this about it's concrete, it's visual. Kids can choose different activities that they want to do, and it can make a big difference for them. So they could, for example, choose between reading a book, listening to music, playing with Legos, whatever. Next slide. The other big area is the sleep resistance. It is true that in kids of typical development, they can fall asleep crying it out, but It doesn't work very well in kids with developmental conditions. They don't understand what's being asked of them. The parents are not willing to do that, and I don't blame them because I wasn't either. I wanted a kinder, gentler thing for my child than having them just cry themselves to sleep. And we came up with this rocking chair method. It can be a chair, it can be a rocking chair, it can be anything that's comfortable to a parent. They're in the room with the child. They let them stay. They stay in the room. They let them fall asleep. But there's not this like parent looks at child, child looks at parent. It's more of a you're there, you interact in a brief and boring way, but you are there. You're comforting the child with your presence, and then you gradually move the chair out of the room closer and closer to the door each night, and then you reward. So it's focused on rewards and not on punishment. So this works really well. Next slide. The other things we do are educate parents about what you have at night is what you need when you wake up in the middle of the night, because we all wake up. But if we're dependent on, like the infant with the pacifying falling out of their mouth, they wake up because it's out of their mouth. The parent in the room with the child, they wake up because the parent's out of, is no longer in the room. They're rubbing their back and then they leave. And the child wakes up in the middle of the night, like we all wake up, and the parent isn't there, and they have a full-blown awakening. So letting the child finish the process of falling asleep on their own without the parent there. Now, one exception I will make is music. When my son, my older son was young, he really needed music to fall asleep. And if the music ended, he would wake up. So what did we do? We got a continuous CD player. Now you can do it on your phone. This was 2003, and it worked really, really well. It made a huge difference. We just kept the music going all night long, and eventually we were able to extinguish the music. But other than that, just be really careful, especially parents, like falling asleep in the room, or driving around with the car seat in the car until the child falls asleep, and then when the car stops, they wake up. So this is a very important principle. Next slide. And then you might want to move your bedroom next to your child's bedroom if it's in another part of the room, so another part of the house, so you can respond quickly to distress. I mentioned the brief and boring. Be careful not to over respond. If you have like a nanny cam in the child's bedroom, every little noise might not be a night waking. It just might be a rustling of sheets or whatever. So be careful there. I love the visual reminders and the realistic goals and the rewards. Next slide. And then bedtime passes. These work in kids who have a little bit of language. I think like 3 to 7 years old, although it could be older depending on developmental level. It's a laminated card that the child keeps with, asks for something in the middle of the night, like a glass of water or a hug. They turn it in, and the parent gives them whatever they need. But then they can try the next time to keep the bedtime pass all night long. And then if they don't use it, they can change it in for a reward. And next slide, we put together a little social story for kids and parents, and it basically goes through what is the bedtime pass, why is it important to get sleep. My parents have made a bedtime pass to help me. It's like a ticket, and I can either keep it and trade it in for something special in the morning, or I can trade it in at night if I need it. And it gives kids a lot of confidence, and it's great for the kids that we used to call Asperger's, because there's a huge need for control in that population. And my sons were that way too. And this pass gave them the control they needed. So they were in the driver's seat. They could decide, do I give up the pass or do I keep it? And after doing it a few nights, it doesn't have to be expensive rewards. It could be go to the dollar store, pick out a bunch of things and wrap them. So after a few nights, my younger son didn't need it anymore. He learned how to sleep through the night. So it's a nice strategy. Next slide. I wanted to point out, if you want to use your phone, this is a QR code that will take you to free resources for not just children, but teens, and visual supports and bedtime passes that you can print out and laminate. And there's a book that I wrote with my colleague Terry Katz in Colorado. We wrote it because we wanted to help parents learn how to do this on their own, because they can't always find a academic place, medical center that doesn't have long waiting lists. So this was our first attempt to try to do it yourselfer for parents. Next slide. And we did our first trial in 2014. We gave parents a pamphlet, or we randomized them to either work with coaches in group or individualized classes. It was only a 90-minute session that they took, and then they had 2 quick follow-ups. And we looked at their sleep and behavioral measures before and after treatment. Next slide. And we found that using a watch, an actigraphy watch, which is like a Fitbit or an Apple Watch, they had improvement in their time to fall asleep if they got either the group or the individual coaching from the educators. They didn't meet significance. They had just a slight improvement with pamphlets and no treatment. They actually got worse, and it was at least a 20-minute improvement. Some kids, it was like an hour improvement in falling asleep, but it was 20 minutes-ish on average. And we also saw improvements in questionnaires and other scales that are listed here, including quality of life and how well the parents thought they were doing as parents, their sense of confidence. Next slide. So we've moved this now into community practices, and every community has a therapist, right? So the idea is we have trained therapists who are comfortable with behavioral education and speech and OT and whatever. The pediatricians and the pediatric nurse practitioners, we just ask them to refer, and we ask them to look for medical co-occurring conditions, but the therapists do all the work. And we've trained them and on our curriculum, and they do great. And the parents love it. And they feel very comfortable with these therapists, because these therapists already know their kids for other therapies that they're receiving. Next slide. And I wanted to just mention, in addition to these strategies that we use that I hopefully have been able to impart a little bit, we occasionally do use medicines. Supplemental melatonin is always tried first. I know it doesn't work for everyone, particularly for night wakings, but it does really work in some kids. It relaxes people as well as promotes sleep, which is why I think it works really well in this population. And there's just been a lot of literature, particularly on its safety. And of course, melatonin and behavioral therapy is the most effective. I mentioned I've been working with a group called Neurum, that is developing a tiny little mini tablet, like 2 millimeters, 3 millimeters, extended release that kids can swallow easily and works all night. We don't have that in this country yet. In this country, you have to take a bigger pill, and a lot of kids with autism can't swallow pills. So that's one of the challenges, but hopefully that will be available at some point in this country. Next slide. So I'm not going to go into it now because I want to save the time for your questions. But I did want to mention that we do have a video that I've developed, as well as blogs, and you can take a picture of the video with your phone. It'll take you to the site with a QR code. And we'll also send out these resources. It's basically something I decided to do because melatonin is not regulated by the Food and Drug Administration. So it's kind of like the Wild West. If you go to the store, you'll find that it's combined with all sorts of things, including chocolate. And chocolate is a stimulant. I love chocolate, but it's not the best thing when you're trying to go to sleep. And then also, it's been baked into brownies and even combined with CBD, which is derived from marijuana. And I know none of you want to give your kids any of that stuff. So, it's you want pure melatonin if you're going to give them melatonin. But questions that parents have for me is, will my child become dependent on melatonin? How do I choose a reputable brand? How much do I give? And my goal with this video and blogs is not just to give you answers, but to help you find the answers on your own. I'm a big believer in critical thinking, and you all are some of the smartest people out there. You know what's right for your child. So rather than telling you what's right for your child, I've written these blogs in a way that helps you figure out on your own what's right for your child. So I encourage you to look at them. I hope they're useful to you. Next slide. I also wanted to mention some of these other medicines that are out there. It's unfortunate, but there are very few studies of these medicines. Bold means that there are some studies, but like trazodone, hydroxyzine, some of these other medicines have not been studied very much at all, if at all. And I just wanted to highlight gabapentin. Medicines like clonidine, they're called alpha adrenergic agonists, and mirtazapine have only been studied in a few kids. Like we're talking like maybe 20 kids, 24 kids at most. I did want to mention that I have had a lot of success with gabapentin. We published on gabapentin at Vanderbilt. It is helpful because it maybe also helps restless legs and restless sleep, which can interfere with sleep. Those are some of the things that can definitely be improved by gabapentin. I don't have any conflict of interest with the people who make gabapentin. I just wanted to highlight that as something you might want to talk to your healthcare provider about. The key is with any of these medicines, they're all prescription, except I guess for CBD. It's just really important to make sure, even with the melatonin, that your healthcare provider is involved and knows what you're doing and what you're giving your child. If you're thinking about a supplement, there's a lot of buzz now about magnesium, and I have people I know it does work in, parents who give it to their children for sleep or take it themselves. Just make sure you talk to your healthcare provider, make sure you're using a safe dose. And make sure it's something that isn't super expensive. That's the other thing I see out there, are parents taken advantage of by people who want them to spend a lot of money on supplements. So, but the key of this slide is that we really just don't have a whole lot of evidence base for these medicines. And I think we, really do need to have more. So let's go on to the next slide. So I just wanted to sum up and say that sleep problems are very common in autism, and they can impact daytime functioning. Once the cause of a sleep problem is identified, sleep disorders can be very treatable, and behavioral approaches do work. So what's happening, if you think about it, is we're not only improving health by improving sleep. When I say improving health, improving obesity, improving heart function, improving our ability to learn and to remember, but we're also improving daytime functioning in the sense of less aggression, better progress in therapy. In some ways, it's kind of counterintuitive. Like a lot of parents don't want to bring up sleep with their healthcare providers because there's so many other issues going on, like aggression and not being able to focus in school and being irritable and whatever. But in reality, the sleep is contributing, right, to those things. So that's why I so encourage you to bring this up as a concern, and also look into some of the things I brought up today with the treatments and the resources that I provided. And then on the provider side, one of our challenges is to get healthcare clinicians to really pay attention to sleep, and it's just so important. And it's frustrating for them because they have to do so many things in their patient, in their clinic. So this model of trying to get them to focus on the medical conditions, and then we focus on everything else, may be a good one. And then, or having the community therapist focus on the actual sleep may be a good one. Medicines have side effects, but they're sometimes appropriate. And we desperately need more studies, medicine studies, behavioral approaches, combining the two. And then your input is critical. Like, what is really important? Is falling asleep in 30 minutes at 9:30 at night as important as not waking up at 2 in the morning? Or what's important about side effects? Would you rather avoid a medicine that could have some side effects? What are those side effects? So all of these things are vital to improving sleep in this population. I'll stop there and say thank you very much for your attention. You're a great audience, and I look forward to hearing your questions.
Amazing presentation, Beth. Thank you so much for your presentation. We actually have a lot of wonderful questions coming in through the chat. And so I'm going to do my best to get some of those over to you so we can take full advantage of our time with you today. We had a question early in your presentation from Victoria S. And I wonder if you could comment on how something like epilepsy affects sleep. And would this potentially cause an additional challenge for some of our autistic patients?
Yeah, that's a great question. Epilepsy, so on the surface, it seems like the way that epilepsy would affect sleep is by having a seizure and waking up. But it's more than that. We know that in epilepsy, we see fragmented sleep. So apart from having seizures, even on nights when kids aren't having a seizure, or if they just have seizures during the day, their sleep is just not normal. And it's not normal like right after, the night after a seizure. So really getting good control of the epilepsy is important. And then even beyond that, realizing that these kids may need something to promote sleep at night. The other thing that I've seen is that oftentimes if there is a sleep problem going on, like apnea, let's say, the seizure threshold could be lowered by the sleep problem. So they're more likely to have seizures. So treating the sleep problem, whether it be apnea or insomnia or something else, is actually, it's like bidirectional. It can help the seizures, and then treating the seizures can help the sleep.
Really helpful, Beth. We just got a recent question here from Noreen, and I wonder if you have any thoughts on sort of sleep architecture in autism, whether or not there are some differences that we know about the amount of REM sleep folks with autism are getting, and whether that can impact things like daytime fatigue.
Yeah, there have been several studies in sleep. We've done some. Dr. Buckley has done some. The challenge with these sleep studies, to be completely honest, is people don't sleep normally in the lab, right? Especially even kids. So it's hard to know for sure what we're measuring. We actually did 2 nights of sleep in a lab because we were worried about the first night being accurate, new place, wires on your head, all of that. And we did not find decreases in REM sleep on the second night, although Dr. Buckley has found that. So there's been some discrepancies in the literature. And it could just be, is the child on meds? What kind of autism do they have? I mean, there's so many different factors. So I'm not a big component or a big proponent of REM sleep is absolutely different or altered in these kids when they go to sleep. But what we do know is that many of them take a long time to fall asleep and they wake up in the middle of the night. And that's where I go back to, it doesn't necessarily have to be their autism. It could be their medical co-occurring condition. It could be some of the challenges they have because of their autism with, let's say, transitioning and needing a bedtime routine, calming their brains at night. So I kind of always take that holistic approach and look at everything.
Absolutely.
For example, actually, if I can comment on one more thing, this was brought up in the cases earlier. What I wanted to highlight is, to me, it's less important if the child has a bedtime routine or takes a bath. What's more important is the bath calming them down? Because in some kids, they have this bath, but the bath revs them up. So I don't ask, I ask if there's a bedtime routine, but I also ask, is the bedtime routine calming your child? And parents will give me this perfect bedtime routine with a bath and everything, but they'll say their child is revved up, in which case I actually move the bath out of the bedtime routine and closer to dinner because it's not helping. So that's the other point I wanted to make in relation to the case that was brought up earlier.
such a good reminder of all those individual differences. We've got a couple other really great questions. Early in your presentation, Amanda H asked a question about what do we do when kids are too dysregulated or unable to tolerate an overnight sleep study? It sounds like in some of your work you've done sort of 2 nights to try to help them get acclimated, but in clinical practice, what can we do in those
Yeah, I mean,
instances?
the 2 nights was more for research to look at REM and other stages. I probably wouldn't torture a child with 2 nights. I would probably just take what I could. So a few things that we do. First of all, if I don't have to do a sleep study, I don't. I only do the study if I'm worried about something waking up the child at night. That's super important. So I want to make sure that it's justified. So for example, if I'm worried about leg movements, I might get a ferritin level, an iron level, as long as the child can tolerate getting their blood drawn. Ferritin is iron stores, and low ferritin or low normal ferritin levels have been linked to restless legs, restless sleep, and disruption, insomnia. But if I really truly am worried about sleep apnea, if I'm worried about the seizures in sleep or something else going on in sleep, night terrors, whatever, and they really need a study. As I said, I have that booklet that I think I included in the resources on how to help your child have a study. I also, we're very lucky at Vanderbilt, we have hotel-based labs, so kids feel comfortable in the setting. We have really good techs who are comfortable with kids. We have them they're allowed to use their iPads or tablets while they're getting hooked up. Parent can sleep in the same room with them, anything that will keep the child comforted. And then if the wires fall off, we work with what we've got. We may not get the whole night, and that's okay. We just want to know if there's something waking them up at night. So those are some of my strategies. There have been some great papers out there on, you're going to be a movie star, you're going to have glittery jewelry in your hair, you're going to have something on your finger that glows in the dark. Some of the really smart kids want to see their study, so I'll tell them after their study, I'll show them their brain waves. They really get into that. And then we can do these first then boards like we put in the visual in the pamphlet that I included that will help. So they can, first sleep study, then we get to go watch Disney the next day or something. So.
Yeah, great reminders there to support that sort of preparation in advance. Megan E actually has a great question that just came through the chat about whether or not there are any valid or reliable options for home sleep studies, given a lot of the wearable technology that's been developed more recently. And also if we should be asking any particular questions to our doctors before starting ADHD medicines with regard to how it might impact sleep.
Yeah, so I'll start with
questions, but helpful.
Yeah, that's fine. I'll start with the ADHD one. Yeah, absolutely. I mean, there are some ADHD meds that are more stimulating than others. The timing can be important, like we talked about with the methylphenidate. So that's really important. And then, as you all know, ADHD can be really challenging in this population because it can cause more irritability, some of the ADHD meds. So yeah, working with the doctor, trying to get the sleep doctor, the developmental pediatrician, and if there's a psychiatrist involved, all together, all talking together. As Amy and others stressed earlier, collecting data, trying to figure out what happens with a child's sleep when these medicines are started. In terms of the home study, it's not so much home sleep studies yet. We're not quite there yet in terms of the wires and all, and getting an accurate study, but we do use these wearables. I mentioned the Fitbit and the Apple Watch, and there are research reliable actigraphy devices that measure sleep and wake based on movement and rest. And these can be great. I mean, you can use these for several weeks at a time, and they can track improvements in behavioral therapies or in medicine. So those can be super helpful. And we piloted that if a child can't wear it on their wrist, you can actually put it in a tight-fitting t-shirt. Actually, Margaret Souders, Amanda at CHOP did that work, I know, several years ago. She was the first, and then we followed up on that. So different ways to get at sleep with wearables, and they're getting better and better. I mean, someday we will have I'm sure someday soon we will have some ways that we can do the sleep study in the home, which would be great because it would be naturalistic and more comfortable for the family.
Yeah, it definitely feels like that's sort of on the horizon here with technology pretty quickly. A couple other questions. A few folks have asked questions about supplements throughout your talk, and I know you talked about some of those and sort of the evidence to support some medications and supplements beyond melatonin. What other supplements would you think about? I know you referenced iron a few minutes ago in one of your comments about restless leg, but what other supplements would be reasonable to consider, and what should people be sort of more cautious or wary about? You probably hear it all, but what would be some things that would be on that
Yeah,
sort of
so I think magnesium is very intriguing. I'm going to start taking magnesium myself just to see. And it doesn't have to be a low level. It will still have benefits. And melatonin's the same way too. Like, people ask me, if I give my child melatonin, am I assuming they have a low level? And not necessarily, because as I mentioned, it can be anxiolytic, it can help anxiety, it can help over arousal. And promote sleep. But I think magnesium is really interesting. So as long as you don't overdose, talk to the pediatrician, make sure it's safe. That's the one that's on my biggest horizon. I think we have to be careful with some of the other ones. I'm very careful with CBD. Parents will come to me and have their kids on CBD. And it's funny because people are more worried about melatonin than CBD, but melatonin is like this track record of being safe for decades. So I am worried about its effects on the developing brain. There are some other supplements as well, like tryptophan, that it's not so much the supplement. You have to be careful about the purity. And I wanted to mention this. It's in the blogs. If you look at my blogs, there's something called a USP designation. So it's US Pharmacopoeia, and you can Google it or look in my blogs, and I have some articles on it in there where it's the next best thing to being FDA approved. So I would look at the supplements and make sure they're USP so that you know that you're at least getting what you're supposed to be getting and not getting other stuff like Benadryl, chocolate, CBD mixed with your supplement. I think that's really important. The supplements I like to use for melatonin are Natural and Nature Made. Those are the two USP approved melatonin products.
really helpful, Dr. Mel. Thank you. We have had a couple of comments and questions, and I think they're really quite important about managing nighttime awakenings. You talked about those already, but what about for those individuals who really show sort of early morning awakening? So it's not so much waking up in the middle of the night, but they're consistently waking up quite early in the morning. It's really challenging, I know, for families, especially who have individuals that aren't safe without direct supervision and support. How do you help support families through those early morning awakenings?
Yeah, early morning awakenings are really hard. And the first question I ask myself is, am I treating the child or am I treating the family? In other words, there are some kids on the autism spectrum who I truly believe only need 5 or 6 hours of sleep and they're done. And maybe as they get older, they'll need more. But if they're 8 years old, 10 years old, and they can entertain themselves and go to bed at 10 o'clock at night and wake up at 4 and they're ready to go, I've never been successful in giving them a medicine to help them sleep more. And what I would recommend is that you set up some Legos or something in the room and they can just entertain themselves until the rest of the family wakes up. And it's a small number of kids, but they're out there. And it's kind of like Thomas Edison was a short sleeper, right? And he invented the light bulb because he needed something to do in the middle of the night when he was done sleeping. So I don't know what it means. I mean, I know it's better for kids to get the recommended amount of sleep, and 6 hours is way too early or too little, but there are kids out there who only need a short amount of sleep. And I think the best thing to do is, rather than trying to put them to bed early and then they're lying awake fidgeting and stimming because they're just not tired, is to let them sleep what they can do and then just work with the family to find a way that they can be safe if they
Yeah, great plug. And maybe some of our hub team members have thoughts about sort of working with behavioral supports or consultants who can sort of help think about making that morning time safe so that parents can hopefully get a little bit more
I
sleep.
like that. I'd suggest building a wake-up box. I think that's a
Yeah.
great idea. Yeah, that's great.
A
You know,
really
I
good
also
one.
wanted to mention, I see Angie Fedley on the phone, and earlier on in my talk, I referenced some of the ATN, now ACNet toolkits, and I gave you a QR code. There's also some videos there now, in addition to pamphlets and quick tips and visual support. So definitely check that out. There's a lot of resources there.
Yeah. Dr. Mallow, couple questions have come in about some other supports for sleep, and I'd love to hear your thoughts on those things like essential oils and weighted blankets. Is there a place for those tools in supporting sleep, and how do you think about helping families use those safely and appropriately?
So that is, it gets back to that one size fits all. I'm not even sure I would ask a parent to go out and get a weighted blanket because they can be pretty pricey. Instead, what I would do is I would start, if I were seeing the child, I would start with really trying to understand what's going on at bedtime, what calms the child, all those daytime habits I mentioned, the exercise and the light and the caffeine and everything. I want to understand what activities calm the child before I go out and invest in a lot of things, especially things that can cost money. So I'm a big believer in start with just the simple things and work with your OT if you have one to try to identify some calming activities. I also wanted to mention if the child has limited verbal skills, those toolkits I showed you earlier with the ACNet, with the QR code, we have some pamphlets on those as well. So the idea of trying different things that you probably have already, rather than going out and buying weighted blankets and lavender scents and everything else, is where I would start.
Really helpful to hear your perspective. I know Maddie on the Hub team has offered some important comments in the chat as well about the importance of paying attention to the individual sensory needs. And you kind of got at that in your recommendation to work with an OT and help think about what helps the child regulate and calm. We'll pop back to a little bit more of a technical question here. For those of you who are on the call, you should have seen a poll pop up. So we're going to keep using this time to pick Dr. Mallow's brain. But if you can fill out that poll for us, that would be really helpful. Anyone else from the Hub team, feel free to jump in if you want to give us updates on how many we've got completed. But the question came in from Sandra B a bit ago about the sort of physiological connection with sleep and autism. Is there a specific area of the brain that seems to be impaired or impacted that's causing sleep disruption?
Yeah, it's a great question. There is a part of the brain in the hypothalamus. It's called the VLPO if you research it, and that sends projections to the deeper parts of the brainstem, to calm down the brain and promote sleep. But from what I've experienced throughout the years, it's so much more complicated than that. Like if you just want to focus on a specific network, you're going to miss the boat because you're going to miss the kid with the GERD and the apnea and the cell phone use and the not getting enough exercise. So rather than focusing on one part of the brain or one thing, I like the approach that I take with those three buckets: the medical, the biological, and the behavioral. I mean, that network of hypothalamus connecting with brainstem, connecting with cortex, would be smack in the middle of the biological bucket. But there's so many more things going on that I don't find it that useful unless I'm giving a talk to really academic people who don't necessarily take care of kids with on the autism spectrum with sleep problems, or who aren't parents. I find it more helpful to look at all these other factors.
I think that's a great place to sort of wrap here. Dr. Mallow, your talk has been so helpful and really redirecting us to those three buckets for people who are dealing with real people in real life and struggling with sleep, I think is so important. So I will pass it back off to the rest of our Hub team who's going to help us through our poll questions. Again, you should see those popped up on your screen. We'd love your feedback if you could answer the questions that have popped up in front of you.
Yes, thank you both so much. Lisa, you did such a nice job condensing and kind of talking about, there were so many good questions in today's chat. And Dr. Beth, thank you so much for covering such a wide ground when it came to sleep. Like you all have probably seen, we have our poll, our satisfaction survey up. Family Echo is so important to us, and we want to know what your response is as families, because that really is the whole core of Family Echo. So we'd love for you to look through our satisfaction survey and first kind of talk about saying agree, strongly agree, neutral, or disagree, whether or not you got some more knowledge. This improved your knowledge about learning about maybe your autistic child and sleep. We also would like to know if you learned about best practices for you as a parent or a caregiver when working with your child. And then also whether or not you got any ideas that you think that you might use. I know Dr. Beth gave us a lot of cool ideas, so many resources. Oh my goodness, I'm so glad we got a lot of different schedules and things like that, different visuals. And then also thinking way back to when Ellen and Sabrina were talking about Casey, talking about whether or not that case vignette was helpful, even whether or not that kind of piqued your interest. So again, our chat or our poll is staying up. I can't see how many we've got going so far, but we would love for you to fill it out just to help us and to also think about what is helpful for you as parents and caregivers. So I will go ahead and turn it back to the team. Thank you all for filling out the poll.
Thank you. And thank you, Hannah. Thank you, Beth, for that great presentation. I mean, I really appreciate you taking the time to like really give us some great advice and some things to take home to think about and go back to our providers with. There's like what worked for them and for their child doesn't always work for me and my child. So go back to your providers and really, talk through some of the things you've learned today. I think the poll is up. Not sure what's going on with the slides, but we will drop in resources for today. You're going to get the resources and the video from this session in a couple of days. We try to get it out in 48 hours. Sometimes it takes a little bit longer. Our next session is on challenging behavior. It's the #1 topic that you all tell us that you'd like to hear more about. We have Nate Call out of Atlanta who's going to be talking about that topic. So plan to join us on February 28th for that. Thank you all for being here. We really appreciate it. And to stay with the theme, I hope you have a really good night's sleep tonight. See you next time, everybody. Thank you.